Well, hello, everybody. On behalf of York Hospital and our Center for Older Adults, I'd like to welcome you to today's Zoom webinar, Better Sleep for Better Health, essentially reviewing how important sleep is to help prevent and diminish cognitive and functional losses as we age. Our presenters this afternoon are adult gerontology nurse practitioner Cassidy Abramson from the York Hospital Center for Older Adults, licensed clinical mental health counselor and sleep coach Lisa Gallo, and polysomnographer Paul Boulay from the York Hospital Sleep Center. Cassidy will start us off addressing risk factors, medical conditions that affect sleep, and sleep aids, and then we'll hear from Lisa, who will highlight what we can do to improve our sleep experience, followed by Paul, who will talk about common sleep disorders in older adults and some available treatment options. Before our presenters get started, we have a few quick housekeeping notes. Our presenters will speak for a combined total of about 45 minutes today, followed by a question and answer session at the end. And unlike traditional Zoom, where you're able to see everybody's faces throughout the whole meeting, during this webinar, you will only see our presenters' faces along with their slides. As participants, your audio has been muted, so if you do have a question, you can type it into the Q&A button located at the bottom of your Zoom screen. Please don't use the chat or raise hand icons, as those will not be monitored during the presentation. And you're welcome to type your questions in at any time during the presentation. You don't have to wait until the end when we do Q&A. If you have a question that has not been answered during our time together for some reason today, please feel free to email us at info@yorkhospital.com, and we'll be happy to send along a reply following this meeting. We also want to let you know that the webinar is being recorded and will be made available to all of you and everyone in the community next week on the York Hospital YouTube channel. So lastly, we are grateful to the Maine Health Access Foundation for supporting this educational webinar to reframe aging and improve care for older adults. So once again, we'd like to thank you very much for tuning in today and spending this time with York Hospital. We hope you find the information helpful, and we're pleased to go ahead and get started as we turn the program over to you, Cassidy.
Good afternoon, everyone. I'm going to start this presentation off. Thank you so much for joining us. I'm going to start it off with a phrase that I think we're all pretty familiar with. So starting off, I've got this slide here that just shows us that there's a lot of belief that we can sleep when we're dead, or we can sleep when we're in the grave. And Benjamin Franklin was actually the first gentleman who mentioned this phrase. And I think our society kind of lives by this. We think we can work really hard and we'll catch up on sleep later. And hopefully by the end of the presentation, we'll all kind of reframe this thought process and understand that every minute of quality sleep is a foundation to a healthy lifestyle and a long life. So just jumping right in, I wanted to show us the CDC guidelines for sleep for older individuals. So I just highlighted here with the arrow that the CDC recommends anywhere from 7 to 9 hours of sleep a night. So if you're sitting at home and you're thinking to yourself, there's no way I get that much sleep, that's a conversation to have with your medical provider right away. Jumping to the next slide, I think most of us, if we're wondering what sleep is, someone might say it's a time where we slow down, it's rest, we recover, we get comfortable and we take a good night's sleep and we dream. Certainly that's fine, but the reality is sleep is so much more complicated than that, and it's so much more important than we can even begin to understand right now. So research is always finding new reasons that sleep is important to our health. And the reality is we sleep a third of our life, and we haven't evolved to require less sleep. So there is certainly a foundation to why we need sleep every night. And I kind of want to break that up for us and start to explain why it's so important. But first and foremost, just a reminder, on this next slide, I'm showing you that around 100,000 car accidents a year, so last year alone, were attributed to drowsy drivers. So if we're not getting a good night's sleep, we're not ready for the next day, and we're not safe for our own health, and we're putting other individuals at risk. So this number was actually down quite a bit from the previous year, and I think it's because people were traveling a bit less during the pandemic. So certainly a huge risk to our overall health and the health of others. But I do want to jump in on this next slide and just kind of explain that we have a trash day every week where we put our trash can out on the street for a reason. And if we didn't do that, things would become chaotic and disorganized, and the streets would be littered with garbage. And the reason that we sleep at night is so that we can get rid of the trash and the toxins in our body. So it's a very, very important period of time. The reality is we're getting rid of toxins all day long through our liver, and we excrete it out in our urine or in our stool. But when we're sleeping, we're processing and removing toxins 2 to 3 times faster. So it's a really important time to remove toxins from the brain. And if I put it crudely, remove the trash from the body. So when we're thinking about an individual aging healthy, if there's a risk factor for Alzheimer's, we really want to just explain to you that when you're sleeping, you're removing those toxins and those byproducts called amyloid betas or tau proteins that are very tightly correlated to Alzheimer's disease. So just kind of skimming the surface here, this is a really important reason why we sleep, is to remove those toxins. On this next slide, I'm also showing you just a couple animations here. When we're sleeping, it's really a vital time for our cardiovascular system to take a break. So we have our lowest blood pressures and our lowest heart rates while we're sleeping. So it's a time where the muscle of the heart can repair itself. It's a time when the vascular system, all of the veins and vessels of our body can recover and take a little bit of a break. So if we have decades and decades of poor sleep, we're predisposing ourselves to cardiovascular risks. I do have a little bit of junk food up here in the corner, and I know we're at lunchtime, so hopefully I'm not making people hungry, but when we don't sleep, we're not able to regulate our hunger hormones, our thirst hormones, our stress hormones. So there's a lot of research out there that shows that shift workers, so individuals like nurses and doctors or factory workers or emergency responders who might have odd hours or work overnight, that they're predisposed to obesity and cardiovascular risks and type 2 diabetes more than the general population, because they're not getting that adequate night's sleep that kind of resets the body for the next day. So specifically talking about type 2 diabetes, when we get a kind of days and days or months and months and years of poor sleep quality, our pancreas isn't able to release insulin in the proper way to control blood sugar when we have sugary foods. So it's important to realize that all of our organs need sleep, and all of our organs function better if we get that quality sleep. And the last thing I want to just kind of touch on here is our immune system has to recuperate and has to build while we're sleeping. So if we think about the pandemic, which has been such a huge problem in our community, we realize that if we're not getting a good night's sleep, we're not ready the next day to fight off infections. So as flu season comes along, as COVID continues to be a problem, we really need to focus on sleep as a foundation for our immune system. And there's a lot of research out there that says that if I gave you a vaccine today and you had a poor night's sleep tonight, you'd probably only build about half of the antibodies that I would anticipate you to build to fight off whatever that vaccine is protecting you from. So just again, skimming the surface of the reasons why sleep is so important. And I also want to just go to the next slide and show you just another breakdown of why sleep is important. If we're not getting that quality of sleep, I just want you to focus on this first comment here about memory, consolidation, and integration. So if you're one of our maturing individuals out there who's maybe in their 70s or 80s, and you're thinking to yourself, I'm forgetting where my keys are, I'm losing things more often, or I'm noticing changes in my memory. Sleep is a huge part about how we take new memories that we learned today. So learning things on this webinar today, you need to have a good night's sleep so that your brain can find a spot for that memory and integrate it into memories that we already have. So think of it like a filing cabinet. So it's got to find a spot to put those new memories. Also, if you think about anything that the brain is doing for our body, attention, focus, sensations, smells, everything is better with a quality night's sleep. And when we don't have that, we're impaired. So I also find it very interesting. There's a couple research studies that say, if we're looking out the window and we had a poor night's sleep the night before, we're interpreting about 10% less that we're visually seeing if we had that poor night's sleep. So again, just think about it. It's impacting the entire body with a poor night's sleep. So just popping to the next slide, I want to talk about what I mean by a poor night's sleep. So a quality night's sleep means that you're achieving all of these sleep cycles. So you can see this graph here, and throughout the night, you're kind of cycling through this whole stage 1, stage 2, stage 3, and 4 of sleep. And the most important stages are deep sleep and our REM sleep. So that's rapid eye movement sleep. And these are the stages where the brain is able to remove the trash and remove the toxins, and where the body is able to reset the organs and get them ready for the next day, or build that immune system, or consolidate those memories. So those are the important stages of our sleep where we can get ready for that next day, and over years and years, build a healthy body and healthy brain. So just to give you a little bit of an idea of what I mean when I say if you're getting poor quality of sleep, it means that you're not achieving these cycles maybe frequently throughout the night or for a long enough duration at night. The next slide I've created for you, just kind of very, again, skimming the surface here, just a couple reasons that you might have poor quality of sleep. And I'll just talk quickly about stress and lifestyle. I do think this doesn't get enough attention. So if you have dogs or cats that are jumping up on the bed, they're waking you up and taking you out of some of those sleep cycles. If the temperature isn't correct in the room, where there's too many pillows, or the bed is uncomfortable, or you're stressed, your body just doesn't feel safe enough to get that quality of sleep, or it can't relax enough for that quality sleep. Caffeine, watching television, or doing something on your phone, the blue lights interact. And so lifestyle is a very important factor in why you might not be getting the quality of sleep that you need. I'm also just going to skim the surface about chronic health conditions. So any cardiovascular risk factors like heart failure, or respiratory conditions like COPD or asthma, of course, they're going to impact your ability to sleep and get the proper oxygen and get that quality night's sleep. I do also feel like pain isn't acknowledged enough. And if we're uncomfortable, of course, we're not going to be able to fall asleep. If we have back pain or knee pain or shoulder pain, we're not going to be able to stay asleep, because when we rotate, it might hurt. So there are reasons why pain might impact our ability to sleep. And lastly, for the older adult population, especially our individuals who have had multiple children, our bladder's not functioning in the same way as we get older. And so if you're noticing that you're getting up maybe 5, 6, 7, 8 times a night, that's a conversation to have with your doctor, because it's certainly impacting your ability to get that quality of sleep. And we will obviously have Paul talking later today on this webinar about our sleep disorders. And we're going to focus mostly on our obstructive sleep apnea, our central sleep apnea, and insomnia. And those are our sleep disorders that can certainly impact your ability to drop into quality of sleep. I do want to just quickly talk about medications. And when we have medications on board, it's very important to realize ones that are beneficial and ones that are quite dangerous. And I wanted to start off with our dangerous ones. So diphenhydramine is the long name for a very common medication that probably most of us have in our medicine cabinet, and that's Benadryl. And Benadryl for many years has been on a criteria list called the Beers criteria, where it's a high-risk medication for patients over the age of 65. And I've kind of listed some of the side effects here, and they're called anti-cholinergic side effects. And just to kind of skim the surface for you, confusion, it's going to cause dehydration, agitation, memory impairment, and for some situations with chronic use of Benadryl, it may require a hospital visit. So it's a dangerous medication to be using routinely. So if you're realizing that maybe you give this to your grandparents or your parents, or you're taking this yourself to fall asleep, have a conversation with your provider, because it's certainly a dangerous medication. It does, as we all know, probably, Benadryl causes drowsiness, so it helps us fall asleep faster, but it does reduce our ability to get into those quality stages of sleep like REM sleep. So it might help you fall asleep, but in reality, it's not benefiting the brain or the body by any means. It's doing more harm than good. On the next slide, I've also kind of included common medications out there that have Benadryl in them. So take a look at these. And when you're sitting at home later today, maybe pop into the bathroom, take a look at your medicine cabinet and see if any of these are there, and then have a conversation with your provider about safer alternatives for sleep. So I just want to go to the next slide and talk a little bit about another myth. So a lot of people believe that a nighttime cocktail will help you sleep better. And the reality is, similar to Benadryl, alcohol is a depressant and it makes us drowsy. So it certainly can help us fall asleep. But again, it's not letting us get into those REM stages or those deep stages of sleep that are beneficial to the brain and body. And it also, for our older adult population, increases confusion, increases the risk of dehydration. And obviously with that can cause more falls at home. So when I'm talking with a patient of mine, I don't say cut cold turkey. You don't have to, like, I don't say you have to get rid of your cocktail. I have an honest conversation with them about how much they're drinking and if they could maybe front load it earlier in the day and maybe have an afternoon drink instead of a 7 or 8 o'clock cocktail for bedtime. So again, a conversation you'd want to have with your provider. Just jumping to the next slide, I do want to talk about things that you certainly can do and that we encourage you to do. So when I'm chatting with a patient who's struggling with pain and getting to sleep, I always go to the safest options, and those would be using Tylenol within the milligram parameters for a daily dose, using heating pads or ice, so topical pain relievers. I also talk about lidocaine or Bengay or capsaicin cream that can be applied to the area that hurts. And again, there's so many different levels of pain medications that we can prescribe for patients. But just today, I wanted to discuss some things that would be lower risk. And again, have a conversation with your specific provider. But I will just do a disclaimer. If you're considering using a heating blanket or a heating source, do not also use that with a topical patch like lidocaine. You will overheat and potentially burn the skin. So again, have that conversation with your provider about what's safest for you for pain to help with sleep. Jumping to the next slide, I also want to talk about melatonin. So this is an over-the-counter medication that helps our sleep cycle. And again, it's a hormone that our body naturally creates. And we'll talk about melatonin a little bit later in this webinar, but it is a safe option that I often recommend for my patients who are struggling to fall asleep, especially as an alternative to popping a Benadryl at night. So you would take this about 30 minutes to an hour before bed and have a conversation with your provider about how much would be correct for you. So I will just leave one more list here for you on this next slide about medications that if these are on your medication list and you've been taking them chronically, it might be time to have an honest conversation with your provider about, are these the safest options for my brain? Are they the safest options for my body? Is it safe now, but maybe not safe in 5 years? So have a conversation and just consider if these are on the list, looking for alternatives. And just to kind of close off today, I want to mention that one of our biggest assets to helping with sleep and getting better quality of night sleep is using cognitive behavioral therapy. And this is a technique that I will pass off to Lisa to explain more about. And it's a great option with a very no side effects, and is researched as one of our best options for helping with sleep. Thank you.
And now we will hear from Lisa Gallo, licensed clinical mental health counselor. Thank you, Lisa.
Thank you so much. My name is Lisa Gallo. I'm joining you today from my office here in Newington, New Hampshire. I'm a mental health counselor. I work with clients in Maine, Massachusetts, as well as here in New Hampshire. The clients that I work with come in for a variety of ideas and support in navigating life and their challenges. One of the areas that people reach out to me quite often about is their sleep. I'm really passionate about sleep and helping people to find more restorative sleep because I myself have suffered from insomnia for a period of time. But I'm lucky enough to be in a profession where I was able to go to get some training, and I was able to resolve the insomnia that I was struggling with. Now, in my practice, I work with people to learn how to improve their relationship with sleep. I'm excited today to share some ideas with you on that journey. Let's get started. And next slide, thanks so much. Sleep can be elusive. We can think of it as something to be solved, something to find, to fix, or something to be achieved. Some people feel it's related to kind of their performance as far as how did they sleep the night before. The good news is that a person often has exactly what you need in order to solve the sleep puzzle. You just may not be aware of what those pieces are. When you start to look at your relationship with sleep in a way that maybe is more curious, you may start to put in some of those puzzle pieces that maybe you weren't aware of before. And with every person, it's different in terms of what they're struggling with. Next slide, please. I'm going to ask you to think about something. I want you to think about going to bed tonight, and I want you to kind of notice if you feel anything that happens for you as you think about that process. For some people, we feel hopelessness or dread, or maybe you're confident that sleep will be there and you just don't have to hunt for it or look for it too much. Now I want you to think about what it can feel like to look at your sleep and the process and journey of sleep from a place of curiosity and openness. This is where change happens for us, and we're often not aware of it. Research has shown us that in order to improve our sleep issues, we have to get to the root cause. What we don't realize is that that root cause is often something that we have within our own power to control. We sometimes think about it from external, like medication. However, there are so many things that we can do from right in our own home to help change our process of sleep if we're struggling. Now, at what point does a person go from, I haven't been sleeping very well recently, to I have insomnia and I have a problem? So as Cassidy said, first you want to meet with your doctor to address if there's any underlying medical concerns. Paul's going to be talking about that in a little bit as well. And then you can also consider something that I offer, and which is available in a multitude of areas, such as online as well, and it's called Cbti. But first, what I want to do is look at what insomnia is and what it isn't. And just on the next slide, I want you to think about when the last time you went to bed and you started thinking about a problem or a situation that you were worrying of trying to solve. And did you solve it at that time? Most people will answer no, that even though they were ruminating about it at night while they were trying to sleep, they didn't really have any great solutions that would have come to them at that point when they were tired. So insomnia is created from a variety of sources, and the example I just gave is one of them. And it's treated by addressing all of the underlying causes. Sometimes these causes are medical, but sometimes the source is our own thoughts, feelings, and behaviors about sleep. Some examples of this are if we try to control sleep rather than letting it happen. Things like inadequate exercise or inadequate exposure to sunlight, worrying about sleep loss, associating the bed with struggling to fall asleep, or rising at very different morning wakes, variety of different times during your week. Also, we can have negative responses to stress that's happening during our day that can impact our sleep. And also lying in bed for too long, feeling frustrated, can also impact our ability to sleep. As Cassidy mentioned, the amount of sleep that we need as we get older changes. If a person doesn't adjust these expectations according to their age and their individual patterns, we can often feel like a battle begins. We can often feel like, well, I used to be able to sleep well, but I must be doing something wrong that now I can't. And it becomes something we have to fix as opposed to explore. And in the next slide, it's just talking about one way of defining insomnia, which is repeated difficulty in falling asleep, or maintaining sleep, or waking too early. And that repeatedly a person may rise and not feel like they have had a restful night's sleep and that they're ready to start and continue the day. I do also want to talk about a couple of different types of insomnia. There's acute or adjustment insomnia, in which the sleep difficulties can last for a few days and a month. This can stem from environmental factors such as a new bed or sleeping in a new bedroom that we're not used to, having excessive room temperatures, such as it being too warm, stress, grief, or as Cassidy mentioned, physical discomfort such as pain. Chronic insomnia is defined as a difficulty sleeping at least 3 days a week for at least 3 months. So what do you do if you're struggling with your sleep and you've ruled out any medical issues? What I'd suggest you do is just sit back, take a deep breath, and try to be open to the idea that sleep education and what we learn about sleep can actually have a tremendous impact in terms of our sleep experience. In the next slide, you'll see a nice diagram that labels these kind of simple things that maybe at first glance you might be a bit dismissive of, but it is important, and the research shows that sleep education is so important. When we change the way we think, when we change the way we behave, and the way we feel about sleep, we can find better, more restorative sleep. And this is proven through research. What's great about CBTI, which is the cognitive behavioral therapy for insomnia, is that there are no side effects. You can do these strategies at home. You can do some of these strategies while you're implementing other doctor recommendations. So let's just get started, because this is a really powerful first one that I want to make sure we have time for. We don't even realize it, but on the next slide, what you'll see is that there are negative sleep thoughts and how they can impact our process of sleep. So just for some examples, remember what we think about sleep matters. So if we're thinking about, I've always been a bad sleeper, tomorrow's ruined now because I can't sleep without my sleeping pills. These are all messages that we're sending to ourselves about how we sleep and what we need in order to sleep. Restructuring these thoughts into positive sleep thoughts are incredibly powerful, and they're one of the greatest things that we can do. It's also one of the hardest things we can do when we're struggling with sleep, but it's worth putting a little bit of time into. On the next slide, what you'll see is that we can work on cognitive restructuring. So once you notice the negative thoughts, try to replace them with more positive ones. These internal messages are so powerful. Use them to your advantage. I'll often ask people, for example, that I work with to write down their negative sleep thoughts on the left side of a piece of paper. And then on the right side, I'll ask them to create a positive sleep statement. So some examples of this are, I'm learning how to improve my sleep. It's possible I was able to get enough of the core sleep that I need and that I'll be able to function just fine tomorrow. Another example is maybe the 2 p.m. coffee wasn't such a great idea. I'll do what I can to get my core sleep tonight, and tomorrow maybe I'll go for a walk instead of grabbing that coffee. I suggest you have some fun with this. You can write down your positive sleep thoughts at different parts of the bedroom or in the bathroom. You can put them on the sticky notes, post them around. Put them where you're going to brush your teeth in the bathroom or next to your bedstand, so that you're reminding yourself. I also suggest that you say them out loud. We send so many negative messages to ourselves during the day and about our sleep at night that we need to really be aware of and work on that cognitive restructuring, which is moving more to those positive sleep thoughts. So on the next page, you're going to see an example of a sleep diary. The research shows that this is one of the most, that we're not all that accurate in terms of how we report our sleep, but that keeping a diary or a log is one of the ways that we can kind of start to notice and slow down and be more aware of maybe where we're struggling or at least where to start. So it's important that you can track your sleep right at the beginning before you make any changes, if that's possible, so that you can begin to collect the data and have an idea of where to go, where to start your interventions, and where to focus your journey on that restful sleep. Some examples on this log are, if you took a nap, how long did you stay asleep? You could track how many times you woke up and how long you were awake at night, or how many hours you spent in bed total versus how many hours you were actually asleep. All of this information is helpful in terms of looking and making up a plan and a strategy for improving your sleep. Now, you don't have to spend the night staring at a clock. That would actually not make a lot of sense, given that's what we tend to do that causes our insomnia, is watching that clock tick. So you just want to have a general idea and take a general piece when you wake up in the morning, and take a general guess, but certainly not staring at the clock. I always make sure to tell people that. It's one of their questions. On the next slide is an example of another sleep log that's been filled out. And as you can see, it's pretty simple and pretty basic, but it can be really powerful in terms of the amount of data that can be collected. And every once in a while, there's a change or two, just a simple change that can make a big difference in terms of somebody's either quantity of sleep or the quality of sleep. So on the next slide, I want to let you know about another interesting thing that people often aren't aware of, that as soon as we wake up in the morning, that we're preparing for sleep that night. One of the things we can do is make sure to rise at the same time every day. Light is the pacemaker for the sleep clock in your body. So when you first wake up, try to get sunlight without the sunglasses on. This is really important because it helps strengthen your sleep system. The longer we're awake during the day, the greater the strength of our sleep system at night. This is something we actually can control. So what you want to make sure to do is, like, when you wake up in the morning, if you can, either go outside and get some sunlight for 20 minutes or so without sunglasses on, because you want to really be able to take that light in through your eyes. That's really important. If you're finding it's too cold or you're not able to get outside, you're certainly welcome to look at a light box, which are fairly inexpensive. And that's something that you can kind of sit in front of for 20 minutes to a half an hour. You want to make sure it has about 10,000 LUX. And you're not going to get a suntan from it. It's not bad for your skin, but you absorb that light through your eye, and it actually starts that melatonin going, which is part of what helps bring us to that sleep. Another thing to just keep in mind is things like blue light that inhibits the production of melatonin, which is what helps our body go to sleep. And so things like that technology, the phone, the device, the TV, all of those things, if they're on at night, are part of what can kind of have sleep be more of a challenge for us. On the next slide, we're going to talk a little bit about our circadian rhythm. There are things we can do to increase the likelihood for a restful night's sleep. One of the things to think about is our body temperature, and we're often not aware of this, but it fluctuates throughout the day and throughout the night. And our circadian rhythm is our body temperature closely linked to our activity, our alertness, and our sleepiness. So when sunlight enters our eyes, there's a decrease in that melatonin, and this triggers our body temperature to rise. This is when we're most alert and we're active. It's usually in the late morning and early evening. As the evening progresses, we want to make sure to avoid that blue light, because if that decreases our melatonin, we're going to end up probably having a more difficult time. If you do need to be on a computer or watching TV, there are blue light glasses that can sometimes help. Now, as we age, our body temperature changes as well. There's not as much fluctuation as there is in young adults or in adults. We tend to rise and fall that body temperature earlier in the day, which is why some older adults find they tend to get sleepy and want to fall asleep a little bit earlier than maybe in years past. Also, the daily variations in body temperature happen less often or aren't as wide as the individual changes. These changes are normal, and it's important to address these changes to obtain quality sleep. So what I mean by that is that we want to make sure that we're aware of the fact if we don't need as much sleep, and that we're doing what we can to support our sleep system right from when we first get up in the morning. Some of the things that Cassidy mentioned, like not eating heavy foods at night, those are all things that can help us in terms of our circadian rhythm. And I'll talk in a minute or two about the environment and how that can help us. On the next slide, this is just a couple of examples of stimulus control. You can use this whether you have insomnia or whether it's just difficulty sleeping. You want your environment to be a cue for what you want to do in that place. And the easiest way to think about it is if we go into the kitchen, usually what we think about is eating or cooking. Now, when we think about sleep, that can get a bit trickier. For example, poor sleepers or people who struggle to sleep, they can have repeated negative associations with their bedroom and with their bed. And then the bed becomes a cue for struggling with sleep or for wakefulness or for being irritable. And it's not a cue for being tired and falling asleep. So it's actually the opposite of what we want when this is a situation. Strong sleepers, their bed becomes a strong cue for sleep. One way to strengthen this is to use the bed only for sleep and only for sex. watching TV, paying bills, doing your taxes. Those are things to do in other areas of the house. We don't want to have mental or physical arousal when we're in bed. We want it to be a downshift and a relaxation and just really easing into that sleep, not having to do things that are going to get us thinking and aroused when we're in that space. There was this interesting study on quote unquote good sleepers, and they were told they were going to get a cash prize for the person who fell asleep the quickest. Wouldn't you know that those given this motivation took twice as long to fall asleep? What this is an example of is that the more we try to sleep or we make ourselves sleep, the more elusive it's going to become. So what we can do when we go to bed is to just learn how to associate the bed with that drowsiness and with that sleep. And I'll talk about how to do that in a minute. But also that you want to try to drift off to sleep and not have it be something you have to make happen. On the next slide, we're talking about some of these bedtime routines. We want to use internal cues. Not going to bed unless you're drowsy, because you're more likely to be worried and to think. If you find yourself yawning and your eyes are getting heavier when you're watching TV, just go to sleep. Just hit a pause or just step away from the show, as hard as it is. Because if we wait for those external cues, like the clock telling us it's bedtime or the end of a TV show or a spouse going to bed, you're going to end up not having as strong a sleep stimulus control. You're going to end up associating being tired maybe with the couch that you're on instead of the bed. You want to turn off all electronics, make sure your bedroom is dark and comfortable and soothing, keeping your bedroom cool so that it's comfortable to sleep. Often if our bedroom is hot, we struggle more with sleep. Now, what happens if you go to bed and you're laying there and sleep just isn't coming? I would say if you can't fall asleep within about 30 minutes, just get up, go to another room, do some quiet activities such as reading for half an hour or so, and then go back to bed again. And then you can continue this process until you fall asleep. So a half an hour in bed, if you can't fall asleep, go on the couch, do something quiet for just a half hour or so. If you start to feel yourself drowsy, then go right to sleep. Be patient, retraining yourself. This takes time. It's about changing our relationship with how we think, feel, and behave around sleep. And so I would just say, even if you've been frustrated heading into this process, try to be patient and know that it does take time, but that it can really help. On the next slide, we're going to talk about relaxation response, but we can't really talk about that until we talk about stress. Stress is a major contributor to poor sleep. We can't always control the stress and where it comes from, but we can start to work on what do we do once we experience the stress or even before we experience it. So the relaxation response is a well-studied, well-researched technique where it's really just about quieting the mind and the body so that it counteracts the stress response. Finding a quiet place, doing things such as a body scan where we learn how to relax our muscles from our head down to our toes, things like abdominal breathing where you breathe through your abdomen instead of the shallow breathing in your chest or your throat, or the mental repetition of a word or a phrase or a cue to trigger that relaxation response. This does take practice. There are examples of how to do this, definitely on the internet, and it is part of the Cbti program, where you learn how to let sleep happen by associating it with that relaxation response. The more you practice, the more you're going to be able to do it automatically. On the next slide, I want to just let you know and leave you with the idea that it is really true that there is hope. I hope some of these ideas were helpful for you, that you can invite sleep, and there are things that you can do to shift your relationship with sleep. And that sometimes small changes here and there can make a big difference. If it's confusing or you feel overwhelmed by this, there are apps on phones that can help track sleep, relaxation, meditation. I know York Hospital has a relaxation line, or you can call that number, and I think that's available all the time. Or you can look up CBTI for insomnia. Greg Jacobs was one of the researchers and has written a bunch of books about it. And also myself, in my practice, I work with people, and there are other providers in the area that can provide some support and guidance if you don't know where to start. You each have a unique relationship with sleep, and working with it and learning about yourself in the time period that you're in the time of your life that you're in can be really helpful in terms of empowering yourself to feel better about sleep and getting that restorative sleep that we all seek. Thank you so much for letting me join you today.
Thank you very much, Lisa. And as a reminder to our audience, if you have any questions for Cassidy or Lisa, you're welcome to type those into the Q&A button. We are going to now hear from Paul Boulay live from the York Hospital Sleep Center. Over to you, Paul.
Thank you. So sleep apnea is when your airflow is reduced or stops. It can happen many times during the night. The CO2 goes up, carbon dioxide goes up, oxygen goes down. And it terminates with an arousal, often with a wake up. Sleep apnea is obstructive when you are trying to breathe, and we can tell with sensors. And very typically you hear a person snoring. This can be because of extra weight, extra tissue in the back of the throat. It can be because of large tonsils. It can be because people put extra pillows behind their heads, which folds the head down, which can make your sleep apnea worse. That's called obstructive sleep apnea. Central sleep apnea is when you are not trying to breathe and you're not moving airflow. And that can happen when you are using agents for pain management, like opiates, OxyContin, oxycodone, and the like. It can also happen when you are not tolerating a Cpap pressure that is required to treat obstructive sleep apnea. We call that complex sleep apnea. And so CO2 drives your next breath for most people. And so some people who live at higher elevations, they can have central sleep apnea. So why treat it? Because there are medical consequences for untreated obstructive sleep apnea. With all those wake-ups and arousals, the sleep is not as restorative, and so you are sleep deprived, and so people are sleepy during the day because they haven't been sleeping well. Consequence of that are cognitive impairment, decision making, an impaired emotional self-regulation, and also if the slow wave sleep is impaired, for a lot of people, this causes weight gain and metabolic syndrome and can cause diabetes. So there are also, with obstructive sleep apnea, there are wide pressure swings in the chest, and this affects the heart rate. We can see what we call respiratory event-driven sinus arrhythmia, where the heart rate goes up and down, and it's associated with the sleep disorder breathing. And we see people on a spectrum of sinus arrhythmia and showers of PVCs and atrial fibrillation, where the heart is not pumping in coordination with itself. And some of these people end up on pacemakers. So also respiratory arousals produce epinephrine, and we have a number of people who come into the laboratory because the patients are not responsive. They have high blood pressure, and they're not responsive to high blood pressure meds. And respiratory arousals also produce cortisol, which is involved in inflammation. So sleep disorders in older adults, and we're talking about sleep apnea, but they also have periodic leg movement syndrome. I just looked it up, and primary cause still unknown, but it's associated with a dopamine deficit, something like as is Parkinsonism, and possibly miscommunication in the spinal column. Some secondary causes, diabetes, low iron levels, Rem Behavior Disorder, restless leg syndrome, which is a wakeful phenomenon, and also sleep apnea. Rem Behavior Disorder REM should be atonic. You should be paralyzed when you are in REM. When people are acting out their dreams, that can be hazardous. And it also is indication of REM dysfunction. So testing for sleep apnea, the gold standard is polysomogram. It's about 30 electrodes representing 20 channels, and it's attended by a technologist with all of that equipment. If anything fails, we need to fix it. And it involves an overnight visit to a sleep lab. This is a sleep lab. The entire visit is about 10 to 12 hours, and the actual test from lights off to lights on is usually 6 to 7 hours. And it's not a hotel stay, it's a medical test. So it's a busy night for a lot of people, but it's a comfortable. So as you can see, this is a Sleep Number bed. It's an adjustable mattress. And we have a high capacity recliner. We have the camera is in the bathroom. It's a private bathroom. We have a TV. We have Wi-Fi. But as I said, it's good. As I said, it's an attended technologist. We're not here. Kick the camera up again, please. So we're not in the room. Actually, there's a pan-tilt zoom camera and an infrared bank. We're in a control room, monitoring the study real time. Monitoring all those channels. So the channels, here's a model of a head setup, about 15 electrodes from the neck up. We look at the neurology of sleep with a partial EEG, an electroencephalogram. We're going to measure off your head with a crayon and a tape measure, find a set of electrodes. The rest of them are references. These 6 are the brain. These 2 are the eyes. And this looks at muscle. Here's a reference that looks at underneath the chin, the genioglossus are lateral to the tongue muscle. Brain, eyes, and muscle. This is how we see the neurology of sleep: wake, light non-REM, deep non-REM, REM sleep, arousals, and wake-ups. Okay, so I've also put a model thermocouple airflow sensor. And ganged up with a repurposed oxygen cannula that looks at nasal pressure. So cold air in, warm air out, vacuum in, pressure out. And this is how we see surrogates for airflow. I think I've put a snore sensor right at the base of the throat. The rest of it is, we have a couple of leg electrodes. Lots of people who are in the laboratory, this is how we see periodic leg movement syndrome. There's a lead 2 electrocardiogram from right clavicle to lower left chest. There are a couple of electrodes low on the side of the chest that look at intercostal muscle tone, which is actually respiratory event. And you can see a couple of belts here. As you breathe, they stretch, and this is how we see respiratory effort. All of these wires, they are funneled into a head box. I usually hang the head box over here by this hook, and the head box reduces most of these wires to 2 plugs, the box and the oximeter, which makes it convenient and expected for you to get me in here. 2 ways. One is the call bell, and another is just the low-tech version is just into the camera. Hey, Paul, I have to go pee. Lots of patients have to go pee during the night. Okay. So a diagnostic polysomogram is to characterize your sleep and to quantify especially respiratory events to see if insurance will cover it per magnitude and frequency criteria. And a treatment polysomogram, if we determine that you have obstructive sleep apnea in a magnitude and frequency that insurance will treat, then we'll do a treatment polysomogram to come up with a plan of care. What kind of pressure, how much pressure, what kind of an interface, and to figure out how well it works and what level. Lots of patients come in with all kinds of fears, and the first that I'm trying to address is fear of the unknown. So this is the lab, and this is what is going to happen. This is what we're going to set up. Some people come in with a fear of the pressure, CPAP pressure, and I'll cover that in just a minute. And I've had a few people come in and are afraid that they're going to become addicted to CPAP. And I tell them that's really the wrong question. If you remove the pressure, the effect of CPAP is immediately reversible. Your airway is going to go back to exactly what it was last night. However, what we want to occur, and it takes a bit of work to get there, is to come up with the right pressure and the right treatment plan so that after 3 or 6 months, you are going to love CPAP and you're getting better sleep, and some of your other complaints that are consequence to untreated obstructive sleep apnea will resolve. That's what we're trying to get to. Some people come in with fear of the testing environment. So I need to use the bathroom several times a night. We were initially fed by a lot of patients from Seacoast Cardiology, and a lot of them were on diuretics. So this is part of it. Most people have to go to the bathroom at least once during the night, and several of them have to go several times during the night. I can't sleep in a horizontal bed. Well, it's adjustable, and we've put patients in. I've titrated several people, many people who can't sleep horizontal, and we titrate them pretty close to what they're usually doing at home up in a chair. But here's a recliner, and it can go down almost flat. Okay. I can't have anything on my face, and this is typical with patients with nasofacial claustrophobia. The sinuses, they don't want anything on their face. And I'll go through some different masks, some of which don't touch that central area of your face. And okay, so first slide, a slide of obstructive apnea. This is what, there we go. So this is in a schematic form. This is what polysomogram is going to look at. So here's an obstructive apnea. The definition of any respiratory event is at least 10 seconds wide, and apnea is at least a 90% reduction in airflow. And oxygen usually follows, but it's not part of the definition. Oxygen usually drops. It's not part of the definition. And obstructive apnea is defined by the persistence of respiratory effort during the event. And you know, a lot of times you can hear the obstruction with snore. Next slide. The hypopnea slide, yep. And so a hypopnea, an obstructive hypopnea is a very similar process. Airflow drops by at least 30%. And the oximetry for Medicare and federal programs require at least a 4% reduction, and private insurers require a 3% reduction. So the definition is a little different, but the process is essentially the same. These are, the oxygen does go down, part of the definition. So these are cardiovascular significant events. Next slide. And so central apnea is also, it's a respiratory event, at least 10 seconds wide. And this is apnea, the airflow reduction is at least 90%. The oximetry usually follows, but it's not part of the definition. But what's part of the definition of a central apnea is that the brain is not making the effort to breathe. And this can happen for a number of reasons, such as opiates. Okay. So your physician may be talking about, and you can let the slide go away. So your physician may be talking about indexes, numbers of times of events. An index is a count of a number of events divided by some kind of time. And what is central to getting treated is an apnea-hypopnea index, these cardiovascular significant events divided by total sleep time. Mild is less than 5, normal is less than 5, mild is 5 to 15, moderate is 15 to 30, and severe is more than 30. And we can also look at other indexes like how much worse are you on your back compared to not on your back, how much worse are you when you're in REM compared to non-REM, and what is the apnea-hypopnea index at your best pressure that we've titrated you to. So treatment for sleep apnea, the frontline treatment is Cpap, and many insurers require us to show that Cpap is either not tolerated or ineffective before they consider alternate treatment. One alternate treatment is a mandibular advancement device, and these are usually initiated by a dentist who is practicing in dental sleep medicine. And in a mandibular advance, I've titrated a few of them, about a half a dozen or something. In a mandibular advancement device, it's like a bite block that is cut horizontally, and the upper block engages your upper jaw, and the lower block engages your lower jaw, and we titrate the lower jaw outwards, and it drags the tongue forward with it, creating airspace behind the tongue. That's essentially what that is. We have part of the York Hospital family. We have family ear, nose, and throat surgery in Kittery. Dr. Brett Rankin, Dr. Christopher Sarno, and Dr. Razar, and they do surgical procedures on the upper airway. What is common is a uvular-pharyngeal palatoplasty, UPPP for short, and they surgically remove tissue from the back of the throat, the uvula, the soft palate, if tonsils and adenoids, if they're there, and some other tissue just to behind there, just to create more cross-sectional area behind the tongue. A couple other procedures are tongue advancement and hyoid suspensions. These are tension members to those structures that pull them forward to create cross-sectional area behind the tongue. InspireSleep.com is something new that we haven't gotten into, but we are working our way to get into. It's also going to be implanted by Kittery Family Ear, Nose, and Throat Surgery. It's a nerve and muscle stimulator. It stimulates the tongue, so the tongue itself moves forward as a consequence. Can you give me that slide, Kim? Thanks. And so the tongue moves itself forward, creating the airspace behind the tongue. If you look at the left larger picture, no stimulation is a cross-sectional schematic of the tongue blocking the airway. And the one on the right, the tongue has moved out of the way. We didn't have access to the videos. It was just the difficulty of getting into this format, but we can get them to those who are interested by giving you a link to their website. It's Inspire Medical. And so in order of left to right there's the base of the tongue, airway, no stimulation, the palate, no stimulation. And then you can see the base of the tongue opening up on the third one, and the one over on the right, the soft palate opening up. So that's something that we are going to implant by Family Ear, Nose, and Throat Surgery, and the sleep laboratory will be titrating the voltage to some therapeutic range in the lab. So Cpap. So a lot of people approach the laboratory and they're afraid of the pressure. I use the tire pump analogy. We're not a tire pump. It's not a tire pump. So a tire pump is going to output with precision flow rate volume. Okay, and the pressure can vary widely. If the tube is open, it'll be low pressure. If you can't physically put your hand on a tire pressure pump tube, you can't keep it there because the pressure is too high. This is not what we do. What we use is a Cpap blower, and the Cpap blower is a fan, and it's more like a parachute, and its output is more precision pressure output. I'll just turn this on. So I can, as soon as this spins up, there we go. And so I can hold my hand here, and it will not build up volume, pressure, anything. Okay, it's going to go to exactly 5 centimeters right now of exactly the pressure that we want it to. So there is a microprocessor which is controlling the fan, and the microprocessor is fed by a pressure meter. And so the output is very accurate in pressure. So you breathe in, you drop the pressure, the machines will spin up, and you breathe out, you raise the pressure, and the machine will back off. If you leak like this, I can make a candle flicker across the room. You can feel that. Okay, so that's what a CPAP device is. Different types of CPAP. So the CPAP slide. There we go. Okay, so in its base form, CPAP is a fixed pressure, and so as a product of the sleep lab, after we titrate it, we may send some people home on a CPAP at some specific pressure, and you'll get that now later whether you're breathing in or breathing out. Caveat is a ramp. It's a get used to it pressure over some get used to it time. The get used to it pressure is typically half your treatment pressure. The time is typically your sleep onset time, your natural sleep onset time. And also, next slide. And also there's something called auto CPAP, where the machine sees respiratory events and that you start generating after you fall asleep. And so the machine will go up kind of fast when it sees apneas and hypopneas and snore. The auto CPAP machine has a maximum PAP and a minimum PAP, and the pressure will move between these two limits. And it'll go along, and if it doesn't, if it floats up there somewhere, it doesn't see anything for a while, it will come down slowly until it starts seeing some more events and it'll kick up. So the effect is that it will, it floats up here somewhere, okay? Okay, and next slide. And so there's something called BiPAP spontaneous and BiPAP spontaneous time. It's a two-level pressure system. And so there's an inspiratory PAP and an expiratory PAP level. And when you put it on your face or nose, you'll immediately see the expiratory PAP, and the machine will see you initiate a breath. It'll swing from the lower to the upper. The difference is called pressure supported ventilation, which helps you to breathe in. And about a second and a half later, it'll swing from the upper to the lower, which helps you to breathe out. And it's driven by spontaneous breathing. And if you don't, in spontaneous BiPAP, if you don't take a breath, it won't give you one. So there is also something called BiPAP ST. And if you don't take a breath in a certain dialed in period of time, it'll give you a mandatory breath. And that's used for certain types of central sleep apnea. And next slide. And so there's something called adaptive serval ventilation. I mentioned complex sleep apnea, I think, earlier. And so adaptive serval ventilation is, you could call it adaptive BiPAP. And what the machine does is it looks at a rolling 3-minute history, and it identifies a target breath. And if through your effort, you are generating a breath larger than a target breath, it won't help you very much. The pressure support will be very low or zero. And if you are having an apnea or hypopnea because you're not making the effort, central sleep apnea, then the machine will give you a large pressure support. So the effect is that it's working complementary to your effort. It's breathing when you're not, and it's not breathing for you when you are. And this has the effect of dampening out these wide pressure, these wide breath volume swings that are the hallmark of central sleep apnea. Okay, the mask. Let's get the heads out. So a full face mask can be a conventional envelope. It can be under the nose. It can also be a total face type. A nasal mask can be conventional envelope or under the nose. You can feed it from the front or a hoop frame, and nasal pillows can feed from the front or a hoop frame. So here's a conventional envelope type full face mask. Okay, this is a conventional headgear, and it feeds CPAP from the front. This is over tightened, and I'll get to that. This is over tightened because these are aprototypically large, larger than prototypical. So this one is silicone. This is a silicone membrane, and these also can come in open cell membrane, which is very comfortable, but you can't over tighten these, because if you over tighten this, there's going to be hard plastic behind it. Okay. Okay. Here is an under the nose mask. And under the nose mask, I put it on this one. I think I put it on this one. And so this is a full face under the nose mask. Maybe. There we go. Okay. And it's feeding from the front. Okay. And like all full face mask, there's a tension member from the chin to the back of the head. Here is a hoop frame under the nose mask. It's a mouth mask, and it's a socket that you put your nose to. And as you can see, with these under the nose mask, this gets the mask entirely off of this problem area when patients with facial claustrophobia complain of. Here's another conventional full face mask, and it has gel. It's a membrane, and it has gel. This is very soft, but it does allow some compressibility. These other full face masks, if there's no gel or foam, this is balloon technology, and it is intended to make a seal against your face when it's inflated with pressure, and if you compress it, it's going to be the wrong shape and it will leak. So there's a definite width between too loose, and it leaks because it's too loose, and too tight, it leaks because it is crushed. Okay, wrong shape. Okay, and okay, so here's a nose mask. And this is a conventional envelope kind of nose mask. And this is, again, the head is too big. And so here's a crushed nose mask. Okay. And so here is an under the nose nasal mask. And it's that nasal socket. And I haven't, we'll just get that out of the way. Here's the nasal socket that you put your nose into. And it goes on really easy. And here is, if you take out this module and put this module in, this is a set of nasal pillows. So compared to a full face mask, where you're looking at a mask area this big, okay, we have now brought this down for those people who have an adequate nasal airway. We've now brought the sealing surface down to that small. And the caveat, you have to keep your mouth closed and breathe entirely through your nose. Okay, so for some people, counterintuitively, for some people, we have been successful when people have severe nasofacial claustrophobia. We've actually been successful counterintuitively with a hockey mask. This is some people call this a scuba mask. It kind of looks like that, okay? And it gets everything off of that mid face that drives claustrophobia for some people. Okay. Okay, so full face mask or nose mask. So any full face mask is, so what I call pharyngeal compression or mouth basket compression. Every full face mask has a tension member between the chin and the back of the head. And what that does is that tension member between the chin and the back of the head, it opens up the jaw, and it sometimes tips your head forward, and it drives the tongue posterior into your airspace, which adds airway resistance to the airflow. and it drives up the apnea-hypopnea index, and it drives up the required pressure. A nose mask does not have it because the nose mask pulls from the maxilla, the upper jaw, above the teeth, which doesn't move. And additionally, so a nose mask doesn't have something bad that all full face masks have, what I call pharyngeal compression, mouth basket compression. Additionally, a nose mask requires a person to keep their mouth closed, predicated upon a good nasal airway. So there's mouth tone and there's the masseter, but we can also see muscle tone in this channel. We can see that on the test. These muscles here, reference to here. And when the tongue muscle has tone in it, the tongue is, when the tongue muscle is not flaccid as it can be, especially when you have a full face mask, the tongue muscle stays where it's supposed to be, in the bottom of the mouth cavity. And where it's supposed to be, instead of with a full face mask, with a flaccid tongue prolapsing posterior into the airspace in something that looks like, that's partial obstruction. Okay, so I have very commonly been able to get a person who is having a hard time with a full face mask to use a nose mask with a chin strap if need be at a significantly lower pressure. That's the effort anyway. It seems like in older people, that's more. Okay. So Cpap Resources, if you are having difficulty acclimating to Cpap, I would say the first person to approach would be the physician who prescribed your Cpap in the first place, and or who may or may not be your primary care practitioner. The dealer of medical equipment can help you with to take a tour of the different interfaces that they work with. Lisa Gallo is a sleep coach. I work in the Cpap clinic under the direction of Dr. Pancho Maslinsky, and I troubleshoot patients and I troubleshoot interfaces. So we have 4 nodes of medical expertise. And so Neurology Associates, Dr. Pancho Maslinsky is a neurologist and a board certified sleep specialist. Dr. Peter Morin and Dr. Anthony Knox are both neurologists. The Pulmonology Associates, we have Dr. Bianca Montero, and who is a board certified pulmonologist, and we have Mallory Evans, who's a certified nurse practitioner. And we have Family Ear, Nose, and Throat Surgery. They have initiated Cpap as well. And so Dr. Brett Rankin, Dr. Christopher Sarno, and Dr. Azar. And last but certainly not least, Dr. Elizabeth Castillo. And with that, I'll thank you very much.
Thank you, Paul, and thank all of you for staying with us through the end of this webinar. We shared a lot of great information. Hope you were able to take it all in, and thank you to those of you who asked questions. We did receive a couple of questions in advance, so we will we'll kind of answer those questions now. The first question that we received was, I've had trouble sleeping since I retired. I feel like I've tried it all. Where do I go next? Lisa, do you think you'd like to help us answer that question from the audience? Lisa might be trying to unmute herself.
Yeah, here I am.
To rejoin us. There you are. Great.
Well, I would say go back to the beginning. And what I mean by that is that sometimes just a reevaluation and a starting of doing a sleep log and seeing what's changed, obviously along with the retirement. So for example, sometimes our sleep schedule changes and we end up sleeping in a little bit later than we have for years. And remember, as I mentioned before, if we're sleeping in much later, we're not getting that light through our eyes right away, which isn't helping our circadian rhythm and helping us actually get prepared and get ready for bed that night. So there can be little changes like that that you can start to look at and kind of see, what's changed since retirement? It may be something as simple as eating or a schedule change.
Wonderful. Thank you very much. The second question that we received in advance It seems like I have had to get rid of so much alcohol, sugar, TV. Is this really necessary for my sleep? And Cassidy, perhaps you could help us with that one.
Yeah, I think obviously we've talked about some of the things that might impact getting that quality night's sleep. I don't want to go over all of them again, but I think if you're feeling like this is a big commitment, it absolutely is. And having, going in kind of like what Lisa was saying, with a positive attitude and realizing that this is going to be a journey and taking the steps necessary. So again, I do have honest conversations with my patients. I don't think it's a good quality of life to say that I have to get rid of things that bring me joy. Like maybe that afternoon cocktail, will bring it earlier in the day and keep it a moderate cocktail, or reduce the sugar but not eliminate, and reduce TV, especially around bedtime. So I think there's things that we can do in moderation. Keeping the caffeine intake down, using decaf or half caffeinated. I think there's options instead of just cutting things out and feeling like you're losing joy.
Okay, thank you. One of our attendees today did ask, what can be done to end night sweats? Cassidy, again, that might go back to you.
So that's a great question. Obviously, without knowing this patient in particular and knowing what health factors are going into this question, I think my gut would first off be change the temperature in the house. Maybe change the sheets. And maybe, at least in the Northeast here, I've got my flannel sheets on, so I would take those off, reduce the number of blankets. But when I hear about night sweats, I think I'd want to hear more. So chat with your provider specifically, because there's certainly many different conditions that would be impacting night sweats, and also medications that might impact that. So medications highly based with niacin might have more flushing reactions that occur overnight, and you could sweat more. You might have medications on your list like SSRIs that might cause you to sweat more. I'm thinking specifically of women in menopause years. It might just be hot flashes. So having a conversation with your provider, ruling out an infection or something more life-threatening would be basically my recommendation. Is chat with a provider that knows you well. And if you feel like you're not getting an adequate evaluation, certainly considering seeing a geriatric provider that might be able to provide more comprehensive exam.
Excellent, thank you. And I think since we have gone over a bit, perhaps we'll have one last question, unless we have anybody out there that still would like to ask a question. You can type that into the Q&A. But we did receive a question. This seems like it would go to you, Paul. Are there times when people just cannot get used to sleeping with a mask?
There can be. And so this has driven some people to go to the alternate treatments. So I mentioned that most insurance companies look upon CPAP as the primary treatment. The mask we can troubleshoot. We can go from one type of mask to another. That's not an unusual patient in the laboratory, but let's hypothetically say they just can't get used to the mask. So I went over the alternate treatments to CPAP, and sometimes that is a pathway.
Okay, thank you.
I might add some comments to that, just because this is a very, very common concern, at least with the patients I see, that they feel they may not be able to get used to the CPAP. I definitely, before even initiating, try to really help patients and their families to understand that this is a process and that it's expected that it will take some time to acclimate to CPAP. It's almost like a stiff pair of leather shoes that initially you can only wear for a short time, and it's uncomfortable and you worry you're getting blisters. And you don't wear those stiff leather shoes for more than 10 or 15 minutes, maybe the first day. With a lot of patients, the goal really is to build up slowly. Actually, I would say with all patients, the goal is to build up slowly. And for people who cannot fall asleep with the mask on, or cannot sleep for more than less than an hour with the mask on, I often utilize something like a very safe sleeping aid like trazodone for a short period of time, so that they can fall asleep with the mask on And maybe after a couple of hours, they pull it off in their sleep. And really all the patient needs to do is commit to putting it on every night, taking the trazodone and putting it on. They don't need to mess around during the night. After they pull it off, then that's fine. Little by little, the body will get used to it, like a pair of glasses or a wedding ring or new shoes. Anything that the body is not used to will take some time, and you can't sort of force your way or work your way to get used to it. You just have to allow yourself to slowly become acclimated and accustomed. In my experience of around 30 years now with patients, there have been vanishingly small numbers of people who couldn't acclimate to CPAP if they were willing to work with all of the support team that's available, trying new masks, working with their clinician, as well as with the people that are from the Cpap or Bipap company. I've had quite a few patients have special custom-made masks just by going into the Cpap clinic or working with respiratory tech. And really all the patient needs to do is kind of not give up, is just commit to putting it on at night and continuing to ask for support. And the vast majority of patients, after they've acclimated to the machine, a year later, a year and a half later, if they get a bad cold and they can't wear it, they tell us they're miserable. They feel awful. They want to be using their CPAP every night because it improves quality of life in their immediate experience. So I would agree with Paul that there are people who cannot get used to the mask, but the vast majority of people who stop are folks who decide to stop, who feel for whatever reason they don't want to keep working with the team and committing to just putting it on at night.
Thank you, Dr. Castillo. And as a reward to 2 attendees who have stayed with us this long, we did have a request for the slides. So if it's okay with the presenters, we would send a copy of the slides out with our special package for everyone that we received the mailing address for, or we can email the slides to people who registered because we have their email address. And our last question for the day, I'm not sure who will want to take it, but how do you feel about CBD or THC gummies for sleep? Cassidy, do you think that would go back to you?
Yeah, absolutely. I think that's certainly a conversation that I think is coming up more and more, especially here in Maine, when THC being so accessible to the community, both medically and recreational. I think, again, it's tough to give a blanket statement without knowing a patient directly. So I think if this comes up in a conversation with a patient of mine, I usually take a peek and look at the medications that they're already on to see if there would be an interaction or an obvious risk that I would see. I think a big thing that I worry about is confusion and change and altering a mental status of any patient who's maybe has multiple chronic risk factors or falls frequently. It certainly becomes a risk in my mind to add something else on board that's regulated from dispensaries, but not regulated through the FDA. So I think, again, a conversation with your provider directly would be my first choice. But I certainly have patients that use it and have a good reaction, but they use it safely and use it and don't operate machinery and don't combine, don't add alcohol involved. And so I think it would be patient specific.
Terrific. So I think that is the last question for today's webinar. We hope you all found the information worthwhile, and we'd like to remind you, if you'd like to receive that package, to please send us your mailing address. You just send us that your address to info@yorkhospital.com. And please keep an eye out for an email from us in the next week. We'll be sending you a link to today's webinar in case you'd like to refer to it in the future or forward it to a friend who might also find it helpful. So on behalf of the York Hospital Center for Older Adults, thank you for attending today and enjoy the rest of your afternoon. And thank you especially to our presenters. You did a great job. Thank you.
Okay.
Thank you.